Welcome back to Rebelcast. I'm your host, Salim Rizai, and this is Rebelcast episode 116, The CLOVERS Trial, Restrictive versus Liberal Fluids in Sepsis-Induced Hypotension. So a little bit of background here. So look, we all know patient meets sepsis criteria, they're getting IV fluids. I mean, it's just part of the standard resuscitation bundle now in septic shock. What's unclear is how much benefit those fluids provide, but it's yet something we all do because it's a metric-driven type of thing. Now, the thought behind why we give these fluids. Well, these patients could have a vasodilated vascular bed, and the initial use of fluids are maybe hypothesized to serve two major functions. One, they can augment the macrovascular system by increasing stroke volume and cardiac output. And the second is maybe they can augment the microvascular perfusion, capillary blood flow. But fluids themselves are not a benign intervention. And maybe we don't see that down in the emergency department, but by the time these patients get up to the ICU, they can start having things like coagulopathy and fluid overload and start developing ARDS, require mechanical ventilation. And these are not benign things that we're doing to these patients. So I'm going to stop there. I don't want to continue ranting. I'm going to stop and introduce my partner in crime. Swami, welcome back. I'm glad we're keeping up with these this time around.
Absolutely. I think all of these fluid type trials we need to get into, and it allows us the opportunity to kind of say, where are we now? What are you and I doing? What are many of the folks that we work with doing? And look at how the data drives us to maybe think about this differently. And, one of the things that you brought up was this idea of perfusion, that microvascular perfusion of the capillary beds. I don't think anyone needs to be reminded that fluids don't have any oxygen carrying capacity in and of themselves. So while the blood pressure might look better, and perhaps there's a little bit more flow to those peripheral capillary beds, it doesn't necessarily mean that the tissue is getting any better perfusion or oxygenation. So we just have to keep in our minds that fluids are not the fix that we probably thought they were. And now we have more and more data telling us that these fluids may not really help. We don't have a ton of data saying that they harm, and that's what we're going to get into a little bit, but we do have a lot of data saying that they don't help that much. One of the interesting recent trials was the sensor trial. We reviewed it on Rebel, so people can go and check that out. We'll, of course, drop a link to that. This was a randomized, double-blind, placebo-controlled trial, basically looking at whether we should be using early vasoactive substances like norepinephrine versus a standard care of placebo in adults with septic shock. So it's really the question of, are fluids enough, or should we be moving early to using these vasoactive substances? And their primary outcome was looking at really stabilization, right? Shock control within 6 hours. Shock control was better in the group that got norepinephrine. A lot of people kind of criticized this and said, well, you gave a vasoactive substance and that increased your blood pressure, so the patient looks better. Is that really a patient-centered outcome? Is it really important for us to have done that? And their secondary outcome of mortality was not statistically significantly different, although it did seem to favor that norepi group. But that kind of sets us up for why we need more studies in this area and brings us to the CLOVERS trial.
And that's exactly right, Swami. And I think after the sensor trial, there was two camps of people. One camp that said we should be starting vasopressors early, and another camp that said, well, hold on a second. We don't really have a good primary outcome here. And so I think a lot of us have been waiting for this trial that you just mentioned, the CLOVERS trial. And the paper that we're going to be talking about today is the National Heart, Lung, and Blood Institute Prevention and Early Treatment of Acute Lung Injury Clinical Trials Network. That is a mouthful. And the paper title was Early Restrictive or Liberal Fluid Management for Sepsis-Induced Hypotension, published in the New England Journal of Medicine 2023. And the clinical question these authors tried to answer, and I think we're going to come back to this because this is not what people may think. In patients with sepsis-induced hypotension, after an initial 1 to 3 liters of IV crystalloids, so let me say that again, after an initial 1 to 3 liters of IV crystalloids, does using a restrictive fluid strategy improve 90-day all-cause mortality compared to using a liberal fluid strategy? So, Swami, go ahead.
No. Your clarification is really important, and we're going to get back to why that's so important in a little bit. But let's talk about what they did in this study. First of all, where did they get CLOVERS from? Crystalloid liberal or vasopressor early resuscitation in sepsis. That's where the abbreviation CLOVERS comes from. That's what you're going to hear this study referred to throughout our podcast, but also across the globe. Everyone's talking about it in terms of CLOVERS. It's a multi-center, unblinded, randomized superiority clinical trial conducted at 60 U.S. centers. So really big multi-center study. So randomization here occurred within 4 hours of patients meeting criteria for sepsis-induced hypotension. And again, they had to be refractory to initial treatment with some volume of fluid. And that was really between 1 and 3 liters. So after they met that criteria, patients were then randomized 1-to-1. And either they got a restrictive fluid strategy, which meant prioritizing vasopressors over IV fluids, or they got a liberal fluid strategy. And in this group, they got a recommended initial 2,000 cc isotonic crystalloid bolus, followed by repeat boluses for specific clinical triggers. There's a nice little flow diagram in the paper. We'll reproduce that in the show notes. But this group got 1 to 3 liters. The liberal fluid group got another 2 liters and then got repeated boluses for hypotension or hypoperfusion. Restrictive group went to vasopressors after that initial fluid bolus.
Yeah, that's a perfect summary and a nice dichotomization that they were looking for. And as far as the outcomes, we already kind of mentioned this in the clinical question. So the primary outcome was all-cause mortality before discharge home by 90 days, which is a nice, strong objective outcome. Other secondary outcomes of note were numbers of days free from the ventilator at day 28, days free from renal replacement therapy at day 28, days free from vasopressor use at day 28, days of ICU need by day 28, and days in the hospital by day 28. As far as safety, initiation of mechanical ventilation, new onset of atrial or ventricular arrhythmias, and then finally complications related to peripheral and central venous catheter use. So I think these are a nice set of outcomes, things that we are looking for clinically at the bedside. And I was pretty happy with those things. As far as inclusion and exclusion, I'll list them in the show notes, but these were basically adults with suspected or confirmed infection that had a low blood pressure, which they defined as systolic blood pressure less than 100 millimeters of mercury, even after the administration of their initial 1 to 3 liters of IV fluids. As far as exclusion, there's really a couple here that I wish they would have included, Swami. And the biggest was patients who had evidence of fluid overload or patients who had presence of volume depletion. I'm talking about these extremes, right? So overload would be like our CHF and renal failure patients, and the depletions would be like our GI bugs, people like having nausea, vomiting, diarrhea, because I think that's where we're finding this like issue of giving too much fluids is really in this fluid overloaded population, but they were excluded, unfortunately.
Yeah, and I think it's reasonable they excluded them. I agree with you. It'd be great to see those patients in the study. But at the same time, I think what this really tells us is that our clinical gestalt about, hey, that patient's fluid overloaded, I don't want to keep giving them boluses, or that patient is clearly volume depleted, I'm going to give them more fluids, that we should keep doing that. That's okay because we're not even including those groups in this study. We're really including everybody else. All the other patients with sepsis that don't have clear volume overload or don't clearly have a volume depleted state.
And the one thing I want to say here before we move on to the results is, in those patients that are clearly volume overloaded, I'm documenting now in the chart, which is allowed, by the way, and meets like the metrics, the checkbox of like, I didn't give a full 30 cc's per kilo of IV fluids because I felt like the patient was volume overloaded. That is actually acceptable now and will get you out of trouble documenting that in the chart. The other thing I'm going to say is that I'm doing it based off ideal body weight. I'm not doing it off actual body weight. So again, just trying to limit the amount of volume so that the downstream harms that potentially can occur with that. I don't know what your practice is, Swami, but that's kind of what I've been doing.
No, same on my side. And it's amazing the number of hoops that we have to jump through in order to do what we think is best for the patient. But this is what it is. So it's a nice little workaround to make sure you're not going to get in trouble down the line. You don't have to worry about that, and you can do what's right for the patient.
So let's get into the results. So 1,563 patients enrolled. And it looked like resuscitation therapies administered prior to randomization were pretty similar between the groups. They both received about just over 2 liters of fluid. The median time from meeting trial eligibility to randomization was about an hour, no difference between groups. The majority of patients got randomized from the ED, so about 92% of the patients. When we look at the resuscitation therapies administered during the 24-hour protocol period, we can see that there was clearly a separation between the groups of about a difference of 2.1 liters. The restrictive fluid strategy group clearly received vasopressors earlier. It was more common, and they were on those vasopressors for a longer period of time. So the authors did a nice job achieving this separation between groups and really trying to establish like these two separate kind of polar opposite groups in terms of their fluid strategy.
Yeah, I really like that because we've kind of criticized other studies where they're like, well, we did restrictive fluids, but then you look at the groups, you're like, both groups got about the same amount. There's a real difference here. 2 liters is a significant difference. And I think that the resuscitation prior to randomization represents what most people are doing. I think most people are at least giving 2 liters before they consider using vasoactive substances. So I think, again, this group did a good job of reflecting what current practice is, and then also making sure to separate, that these groups actually got separation between what they received.
So Swami, let's get into like the critical results here. So we already kind of talked about the amount of volume and the separation, and even at the 6-hour mark, there was good separation. So that continued over the next 24 hours. But let's talk about the vasopressor use in the first 24 hours after randomization, and then let's talk about some of the primary and secondary outcomes.
Yeah, so when you look at vasopressor use in that first 24 hours, in the restrictive fluid group, it was about 60%. In the liberal fluid group, it was about 37%. I'm actually surprised that there wasn't a larger gap between those two. You would have thought in the restrictive group you would have a higher vasopressor use, but this is what they got. And when it comes down to their primary outcome, which, Salim, we're now 12 minutes in, we haven't even discussed the primary outcome, so let's make sure that we state this really clearly. 90-day all-cause mortality, the restrictive group was 14%. Liberal fluid group was 14.9%. That is an absolute difference of just about 1%. Which was not statistically significantly different. And we didn't really talk about how this study was powered and the statistical stuff that went into this, all the methodology, but they were looking for about a 4.5% difference in mortality between the groups. Obviously, this 1% or almost 1% doesn't quite meet that. And this study was actually stopped early for futility. They wanted to enroll somewhere around 2,400, 2,500 patients to get to that 4.5% difference, and that difference with a 90% power. But at that second stopping point where they analyze their data, they're like, we're not going to get there. There's no way we're going to get there. So they stopped data collection at that point.
We'll list all the strengths and limitations. There was essentially no difference in any of the secondary outcomes as well. And then also when they looked at that primary outcome for like pre-specified subgroup analyses, they really didn't find a difference with that either. So essentially it didn't matter which strategy you used. There are lots of strengths and limitations. I don't want to get too lost in the weeds, Swami. I want to kind of jump into the discussion. And the first thing I want to start off by saying is one of the kind of issues that I've seen across multiple different sites, multiple people's analysis of this paper is that maybe one reason we didn't see a difference was that the patients that got enrolled just weren't really that sick. Like their baseline systolic blood pressure was 93.5 millimeters of mercury. The baseline lactic acid was 2.9. Only 60% of patients in the restrictive group even required vasopressors at all. And you already alluded to the fact that you were surprised that more patients didn't require vasopressors. And then when we look at the overall mortality rate, approximately 14%, I don't know. I'd like to think that maybe we're just doing a better job managing sepsis, but it could also just be that these patients just aren't as sick. When you look at some of those big randomized trials from several years ago, like the PROCESS trial, ARISE, and PROMISE, mortality rate was anywhere from 18 to 30%. So I hope this is that we're just taking better care of people. But one of the knocks on this trial is these patients just weren't that sick, and we probably weren't going to find a difference.
I agree that this group may not have been as sick as other groups that we've seen. They're clearly not the sickest subset of patients with septic shock. But Slim, I think this kind of represents a lot of what we see with septic shock, right? That soft blood pressure, right around 90 millimeters of mercury for the systolic, a lactate above 2, but not necessarily 4 or 6. So I think this is a large group of patients that we see. In fact, it is probably the majority of patients that we see with sepsis and septic shock. And so I think it does reflect most of what we're seeing. And I think we just kind of have to look at it that way and say, well, for most of the patients that we see with septic shock, this probably does apply. For that sickest subset, it probably doesn't, just based on what we're seeing here in terms of the demographics.
That leads me to my next point, Swami, which is one of my biggest issues with these sepsis trials, right? And that's that even it's not just CLOVERS, it's all sepsis trials. It's that we lump all these patients together. And even as you're trying to go through devil's advocate of like why like this is probably what we're seeing anyways, and I don't disagree with what you're saying, by the way, but this is such a heterogeneous disease, a heterogeneous process, and the physiology and pathology in patients is probably heterogeneous. Yet we lump all of them into one big trial. We create this like dichotomy, and then we say, oh, look, we didn't really find a difference. Well, you're probably never going to find a difference anyways, because when you lump a bunch of heterogeneous disease processes and illnesses together, it's all going to have a regression to the mean. And to me, the bigger message here is that clinical judgment is still alive in sepsis. It's alive and well. And one black and white protocol, restrictive or liberal, is probably not going to work or be found to work for a heterogeneous disease process. And that's like my biggest issue is like, I love all these trials. I love digging into them, but we can't just keep lumping all these patients into one big group.
Yeah, I agree with you. I think that it is a big challenge here. Sepsis is such a bucket kind of diagnosis. It's kind of like saying, I'm going to do this intervention for cancer. And we know that wouldn't work because, you know, there's so many different kinds of cancer. It doesn't quite work that way. Sepsis, probably not quite as heterogeneous as cancer, but still, I think that point is really well taken. And what it, again, comes back to, I know you said it, I think it's important for us to say it again, our clinical gestalt of what the patient in front of us needs is probably going to be more powerful than any protocol that we come up with, any data set that we come up with, because each individual patient is going to be slightly different. So we can sit there and be like, well, I'm going to give a 500cc bolus. Nope, that did not seem to make the patient better. They did not like that. Let's move to vasopressors. So we have to be able to do that in real time with the patient in front of us. And I don't know that we're going to get much more guidance beyond, well, what we see based on the data is that giving them a ton of fluid isn't better. So you don't have to do that. Just look at the patient and decide what you think is going to be best for them. And I think if we take that message from CLOVERS, that's a pretty powerful message.
I agree. And there's one last message that I just was kind of hidden amongst all the kind of the bigger messages. And that was 500 patients who got peripherally administered vasopressors. So they got it through a peripheral IV. And there was 3 instances of vasopressor extravasation. And they looked at that number of those 500 patients that actually occurred. Those 3 instances were in the first 72 hours of randomization, since randomization. Now, the good news is all 3 events resolved without intervention and did not have any residual clinical consequences. And I think we saw that in the SENSOR trial as well. There was a bunch of patients who got peripherally given vasopressors, and there was a handful of extravasation events, but it was the same message. It was nothing bad.
Right. And what this should tell us is that peripheral pressors are safe. You should have a protocol to do it, and you shouldn't be limited in giving vasoactive substances by saying, I've got to put a central line in to do it, which we know has been one of the barriers to giving vasoactive substances. I think all of this accumulating data tells us it's fine. If you put in a good peripheral IV, it's totally fine to run your vasoactive substance through that, but make sure that it's a good IV and make sure you have a protocol. Make sure you're checking those limbs to make sure that they are not having extravasation and not having some other complication.
All right, let's get to the conclusion here, Swami. So the author's conclusion, I'm going to quote them. Among patients with sepsis-induced hypotension, the restrictive fluid strategy that was used in this trial did not result in significantly lower or higher mortality before discharge home by day 90 than the liberal fluid strategy, close quotes. And That is a factual conclusion. It wasn't better, it wasn't worse. What's our take-home message?
Pretty similar, but just a little bit more nuanced. In a group of patients with septic shock, sepsis-induced hypotension, receiving an initial treatment of 1 to 3 liters of IV fluids, a restrictive fluid strategy with early vasopressor use did not result in a significantly lower or higher mortality before discharge home at 90 days compared to a liberal fluid strategy. And basically, we should remember that this is a heterogeneous disease process of sepsis, and we should be using our clinical judgment to determine, does this patient need another fluid bolus, or should we be moving to vasoactive substances? Either route is totally reasonable, and it is up to us to make that decision.
Couldn't agree more and couldn't have said it any better. And there you have it, Rebel Yammers. Would like to hear your thoughts, questions, and comments. And until next time.